Treatment notes. Objective measures of language style point to clinical insights. Part 3. 2 clinical vignettes from Case 50T1. Spring 1952. A sequence in the middle of May illustrates how the clinical discussion confirms the linguistic measure of increasing MHW in the analyst's emotional connection to the patient, as reported in the notes. The analyst communicates that he understands the patient's affective state and his conflicts about his close feelings toward the analyst. At the beginning of the week, the patient described interactions with a woman with whom he had made several unsuccessful attempts at intercourse. This woman has been in treatment with an analyst the patient himself had once consulted. In his associations, the patient discussed a variety of issues referring to anal stimulation and fears of homosexuality. When the analyst touched on these homosexual references, the patient became defensive yet continued with associations from his past, including a dream of walking into a bathroom and seeing a gray-haired woman on the toilet who reminded him of his mother. The patient came to the session the next day and said he felt good facing a lot of these unpleasant associations, perhaps because the analyst was forcing him to look at himself. After greater elaboration of a variety of sexual fantasies and themes of being forced, the analyst noted to the patient that comments about being forced coincide with his being more open in the sessions. He was acting as if he was not responsible for communicating these fantasies, as if the analyst was forcing him. The patient reported the next day that he was troubled about the previous session and that even when he is talking freely, there are thoughts he is withholding. The patient thought that his speech is a cover for things he doesn't want to talk about. The analyst touched on the transference situation by asking whether that withholding was going on at the moment. The patient agreed and reported a dream with a variety of sexual scenes taking place on a trip he was planning to take. This association about a trip, along with other associations, led the analyst to wonder if the patient isn't concerned about the vacation. The next day, the patient reported that he doesn't like to think he would miss the analyst or would need him. The patient associated to his brother and made a negative comparison about the size of his own penis. This led the analyst to say, "So if you rely on your brother, it means that you are less than him. Therefore, you must make your brother less than you. Otherwise, you will feel you have a small penis." In this sequence, the analyst communicates an important thread, that the patient is concerned about the vacation. The analyst made several references to transference manifestations, the patient being more open in the sessions, and then feeling forced, asking whether the patient was withholding at that moment in the session, and connecting the patient's associations to the upcoming summer vacation. In this material, the analyst certainly does communicate his understanding that the reason the patient cannot feel reliance on other men is that he would feel less manly. To avoid feeling dependent on or connected to other men, he needed to build himself up by making them inferior to him. The dynamic that is explicitly discussed in these sessions is reminiscent of the transference interaction in the first session and the connection to Dr. Z and the young man in the second session. The patient's problems with men and his defensiveness against feeling close to them, implicit in the first sessions, were made explicit in this material. The patient wanted to avoid feeling dependent on the analyst in order to protect himself from feeling that his was the smaller penis. The significance of this piece of analytic work was confirmed the next day when the patient, in the context of his concern about the size and presence/absence of his penis, revealed for the first time that he doesn't touch his penis when he urinates. This led to an important genetic root in the patient's early adolescence, his suffering an injury that made him very anxious. Given our contemporary interest in understanding and addressing the transference most explicitly, it is striking to read the analyst's notes as he continues to write. These injuries are not associated with real traumas, and I am puzzled about them. He digresses to talk about how much more comfortable he is with me. The use of the word digresses is notable. Today, we would not consider a patient's focus on the transference of digression. Whether this view of transference as resistance to exploration of genetic material was idiosyncratic to this analyst and his supervisor or expressed a more pervasive theoretical stance is, of course, impossible to tell. The analytic week ended with the patient bringing up Miss E, another patient in the clinic with whom he has had a variety of flirtatious interactions and who comes up again just before the summer vacation. The patient, according to the analyst, said, "He is waiting for me to tell him why he uses her. He wants the answers from me. He knows I won't let him lean on me." In this analytic work in May, despite some limitations, the analyst communicated that he understood the patient's dynamics and how they were being played out in the transference. As indicated by Figure 1, this coincides with increase in the MHW/REF difference score, which approaches the positive zone for the first and only time in the treatment. Summer 1952. This gain is lost in the next segment. The description of the analytic work in July, just before the summer break, indicates that the analyst did not continue to communicate to the patient that he understood how upset the patient was about the summer break and that the patient had to deny his closeness and dependence on the analyst. The analyst focused on the patient's aggression without communicating to him that would be valuable to understand the meaning of the aggression, including a possibly defensive stance against missing feelings stimulated by the impending summer break. In the beginning of July, the patient reported he had been upset all weekend. Everyone was away and he was alone. This is always disturbing to him. He was thinking it didn't pay to come back here for the next 2 weeks and had a fantasy that he would stop and that I would call him and that he wouldn't come anyway. The analyst does not report how he responded to these comments. However, in sessions shortly after this communication, he describes how he focused on the patient's provocative remarks, which he writes, were intended to get an angry response from me. I point this out to him, and he agrees, but much too quickly. It's as though he wants to have me fit into his picture of me as the cutting person, but this also frightens him. He talks about JS vagina being hidden, that he can't see it, and I suggest that it is as though she has a penis, but he can't see it. There is no reference to the upcoming summer vacation. By the middle of July, the analyst reports that the patient is more aware of his need to provoke me, to get me to speak to reassure himself. I think actually to attack him anally. He had a dream Sunday night after wandering around downtown and denied to himself that he had any homosexual urges. In the dream, he was with an unknown man, and he gets the man to agree to lay for him. Then he cannot find the vagina and looks for the rectum. Just as the patient is about to insert his penis there, he wakes up. On awakening, he has a sudden feeling that something is about to enter his rectum, and he became very panicky. The patient continued obsessively about sexual issues, and the analyst states, I utilize this to stress the anal material that has come out and his preoccupation with his rectum and the pleasurable experiences he has had with it. I am able once again to stress his provocative behavior with me lately. Last night, he took Miss E up to his apartment for the first time. All during the evening, although he did not have any intercourse with her, his thoughts were about what I would say if I hear about it. I point this out as acting out of his need to provoke me. His fear of my reaction is his fear of his own aggressive wishes toward me. The acting out is also a denial of his passive wishes toward me. On the last day before the summer vacation, the analyst writes that the patient spends the whole hour in praising me. How good he realizes I really am, how much he has learned, how he has learned to be able to face his aggression, and so forth. He is even willing to see his passivity with Missy now. It is her responsibility, not his. He relates it to his impotence in withdrawal from dangerous situations. Even during intercourse, the woman has to put his penis in the vagina. In this way, she is doing it, not him. It is her responsibility. I think this also refers to a desperate attempt on his part to say that I am leaving on my own, that he isn't killing me off at this vacation. Several themes in these sessions stand out, particularly the analyst's lack of addressing the connection between the patient's associations and feelings and their possible connection to the vacation. It is striking to note that the analyst was able to do that in May, but couldn't, or at least did not report it, just prior to the vacation. Certainly homosexual feelings are on the patient's mind, and one can only conjecture the connection between those feelings and the upcoming break from the analyst. What is most apparent is that the analyst focuses on the sexual content and the patient's aggression. He discusses the patient's anal pleasures and focuses on his provocative behavior. He does not report that the provocative behavior may have meaning, perhaps retaliation against the analyst for leaving or a defense against the patient's attachment, love, and feelings of missing someone. The homosexual dream with the unknown man may well represent fantasies about the analyst, yet that is not reported in the material. The patient's complex feelings about the analyst, the closeness, the sexual fantasies, the retaliatory and/or defensive aggression were not addressed analytically. Little wonder the patient took another patient to his room. All the analyst could communicate to the patient was that this action was provocative to the analyst, with no understanding of the complex meaning of this action. On the day before the vacation, the patient felt almost coerced to agree with the analyst. He felt he had to please him, echoing the analyst's formulations back to him before they separate for the summer. The analyst's lack of appreciation of the patient's real closeness to him continued in September, fall 52A, when the MHW reaches its nadir. In the first week of that month, the analyst reports how the patient stressed he did not need the analyst over the summer. The analyst writes, he recognizes that he protested too much. You are afraid of your need to submit, which is the only way you feel you can get your father to love you. The analyst focuses on the word submit rather than love or connection, and on the father rather than himself. In short, as in the first session of the analysis, and unlike the May sessions, in July the analyst focuses simply on the patient's aggression without noting the attachment, love, and sexual feelings he has toward the analyst, or his defenses against those feelings. This lack of focus on feelings of missing the analyst continues in September. The clinical comparison between May and July through September is mirrored in the linguistic measures. The MHW is rising in May and then declines in the summer toward its nadir when the analytic pair return from vacation in the fall. It is significant that the understanding the analyst was able to communicate in spring 1952 was temporary. Linguistically, the MHW stayed down until spring 1953 when the analyst told the patient that analysis should not continue and terminated the treatment at the end of the second year. Clearly, the patient was correct in his assessment that the analyst would not let the patient lean on him. In a contemporary formulation, it would be conjectured that the analyst could directly address neither the homosexual transference nor the close bond the patient felt for him, and that this resulted in termination of the analysis. This conjecture is confirmed in April 1953, when the analyst writes that the patient wishes that the analyst do something and wants to fight instead of analyzing. In the midst of attacking the analyst, the patient suddenly brings in his thoughts of being a woman. The analyst concludes the session by telling the patient that homosexual thoughts seem to be so much on his mind and so frightening that we should examine them. They come up often, but he seems to run away from them. From our perspective today, it seems this is the first time in the analysis that the analyst actively addresses the patient's defenses against a homosexual transference. However, immediately after this session, the analyst writes that in supervision it was decided to continue the analysis no longer than the summer because the patient seemed unable to tolerate it. Meanwhile, it was suggested that I continue to abstain from his provocations to talk. Can one safely conjecture that in supervision, given the tenor of the times, there was a discussion about homosexuality that led to a decision that the analysis be terminated? Certainly, this sequence illustrates Kantrowitz's idea, 2002, that the supervisor has an effect on the analyst-patient dyad. In short, the patient expressed feelings of connection to the analyst. The analyst reinforced the patient's fantasies that connectedness is a sign of weakness and castration. The patient became defensive and fought with the analyst to counter his feelings of weakness. When the analyst did not seem to understand that he needed to communicate in July, as he did in May, that the patient needed and wanted him, the patient displaced those needs to Miss E. The analyst in essence did not communicate that he understood either the patient's needs or his defenses against them. We suggest that the availability of language scan graphs at the time might have communicated to both therapist and supervisor that the treatment was working well in May, when the analyst reported the material in an emotionally engaged way, but entered a troubled area in the summer and fall of 1952, when the analyst reported the material in a distant, less emotionally engaged way. Awareness of the linguistic measures might have allowed recovery and progression of the analysis. Clinical description of patient 70T3. Case 70T3 provides a striking contrast to 50T1 in terms of initial presentation, initial assessment, and course of treatment. The treatment, evaluated as successful at the time, showed increases in both the GAF and PFS aggregate scores, ending well above the clinical criteria scores on both measures. The patient was a married professional woman in her early 30s with 2 children. She had had recurrent depressions that at times would become severe. She was unhappy and dissatisfied with her life, but wasn't sure why. The summer before the analysis was to begin, she had found herself on vacation at home, unable to leave the house for approximately 3 weeks. In contrast to the uniformly positive initial evaluations of patient 50T1, the senior interviewers had mixed feelings about this patient. One evaluator considered it difficult to evaluate the severity or modifiability of the patient's pathology. She did, however, seem like an intelligent, motivated person who might be able to tolerate an analytic therapy without too severe disorganization and with considerable benefit. A second evaluator found an acting out tendency, which might cause concern that the patient would leave analysis if her depression got either much better or much worse. Yet the patient herself fears the acting out, and my guess would be that a stable transference would develop and function much like the relationship to her husband. As to prognosis, analysis may not be able entirely to resolve the patient's chronic depressiveness, but there is reason to hope that the severity of the depression might be greatly mitigated with analytic insights. Because of this, as well as pedagogic interest, I would recommend the patient for acceptance as a difficult second or third case. The student analyst was concerned about the amount of acting out the patient had displayed in the past, in terms of both promiscuity and homosexual behavior. There seemed to be a possibility that this propensity to action might take the patient out of analysis before she had a chance to examine her feelings. The supervising analyst was less concerned about this, and took as a good prognostic sign the fact the patient had been able to make a good marriage and had a trusting relationship with her husband. An especially good prognostic sign, he thought, was that she had maintained a relationship with her parents despite her feelings of being constantly rejected by them. One may speculate about the positive impact of this supervisor's opinion on the course of the analysis, in contrast to the negative impact of the supervisor in case 50T1. See Kantrowitz 2002. This patient's diagnosis was depression. Regarding analyzability, her prognosis was good, though there were questions about it. She appears to have been given a less positive prognosis than patient 50T1. At termination, the patient remembered how angry and fearful she had been at the beginning of the analysis. She said she was pleased to have been able to work with the analyst. She said she had other things to say that she couldn't say directly to him, but that she hoped at some point to be able to put them in writing. She was able to talk in a nuanced way about many issues in her family relationships that worried her, and about her concerns regarding her ability to manage on her own. She was pleased with a new job that would begin in the fall, and excited about preparations for a family celebration. Utility of language scans in trying to understand the progression of this case. In parallel to the discussion of case 50T1, we examined the scan of the language measures to try to understand the achievement of a positive outcome in this much longer treatment, 5 years, 9 months compared to 22 months for 50T1. Looking at the language scan, the beginning of the analysis was marked by high MHW and a positive difference score, which then declined during the next 2 phases of the treatment, dropping to a first low point and negative difference score from October 1972 through March 1973.